Thank you, Dr. Vano. Bismillah ar-Rahman ar-Rahim. Good morning again. It gives me great pleasure to share with you our experience in patient dosimetry. Actually, what I'm going to present is representing Dubai Health Authority mainly, although that we have 4 health authorities within the United Arab Emirates. The topic is on patient dose registry and DRL in digital radiology and interventional radiology. This is for the data taken from 3 hospitals and the BHC within the Dubai Health Authority. The outline of the presentation is that I'll discuss first the differences between digital radiology and conventional radiology. Then we'll move to radiation dose registry and mainly DRL. Then we'll end with the discussion on the Dubai Health Authority experience in patient dosimetry. Well, most of the radiology equipments nowadays is digital. We are at the DHA completely digital. We have no films anymore since 2009. The advantages of digital radiology over conventional radiology is tremendous. This is mainly related to the advantage of having wide contrast dynamic range, the possibility of post-processing functionality, and also the multiple image viewing options. Also, which is very obvious with the digital radiology, is the transfer of the images electronically and the archiving possibilities within mainly the back system. This has introduced tremendous advantages in dose reduction. So mainly of the doses has been noticed that it's been reduced in the range of 30% to 50%. And in our experience, we have come across data that reduced the dose reduced by 70%. But saying that, there is still a risk of overdose or overexposure in the DR system compared to the conventional radiology. Conventional radiology, it's very easy to see the overexposure or underexposure because of the black or white of the film, while in the digital radiology, it's difficult to observe this very quickly unless you have a system of monitoring and auditing. So that's why it's radiation doses registry and DRL very important in the digital radiology. Just a quick overview on the material being published by the ICRP mainly on diagnostic reference levels. It was started as that diagnostic reference level, investigations level, then more explanation, more advice, recommendation went through over the years. I will not go over all this, but as you see, from 1991 till very recently, meetings and recommendation are published and gathered on this important subject. Having said that it started by the publication number 60 in 1991, we can see that also in some countries, this established well before that, like in UK, it started in early 1980s. If we look to the definition of the diagnostic reference level, it's a level that's used in medical imaging with ionizing radiation to indicate whether in routine condition, the patient dose or administer activity, because this is also applied to nuclear medicine, that for specific procedures is usually high or low for that procedures. I will give here some recent highlights on the topic of the DRL, the ICRP publication number 121. It said that the development and regular updating of local, regional, and national. So we have to know the limits of the DRL, that it can be from area-wise, it can be either local or regional or national. So it assists in the optimization process in encouraging regular audits for referral cases. Also, it's mentioned in the ICRP dose that no specific quantities, numerical values, or details implemented for DRLs. So it's left for the local place to decide which quantity they go for. Here are some quick descriptions on the DRL, because there is a lot of misunderstanding for the DRL as like dose limits. Actually, DRL is not dose limit. DRLs are quantity used to optimize the procedures that we have. So it's optimization tool. Quantity used for DRL is very important to be simple, to be understood by radiology team, radiologists and radiographers. DRL should be always go in parallel with image quality, so that we don't reduce the dose to a level that we cannot get the information from the radiology examination. Quantity used for DRL should be easily measured. There are a number of quantities in the literature that usually used for the DRL, like entrance surface dose and air kerma. And also imaging parameters are used as to set the DRL, like in fluoroscopy, the fluoroscopy time, or the number of frames. As I said, that diagnostic reference levels are not those limits. They are like investigation level. They are not applicable to individual patients. So what we have to do is we have to carry out a survey on minimum of 20 examination, common examination, and we have to consider also the size of the patient, because this is affecting the value of the dose. The main objective is that it has to be a dynamic process and surveyed in an interval of years, like 3 to 5 years. In UK, they go for 5 years. It has to be measured, that the methodology that it's used for those evaluation are either it's directly measured, like TLD, or any sensors, but this is very expensive and tedious procedures, or it goes for the measure of the kerma in air and multiplied by the technique factors. This is mainly mentioned in the IAEA technical report series, number 457. So the methodology is explained there. Also, the availability of dosimetry devices within the recent equipment can give us an indication of those values. Manufacturer-dependent dose, although that there is a large variation in this, and also the mathematical method that it's used, like Monte Carlo techniques. These all methods used to evaluate the doses. DICOM information, we can extract the information from DICOM information, and we get the dose values, but these has been, this shows a large variation, something like 20 to 40% in the examination. Here just I'm showing a very quick example on what we have done in the DHA. We looked into the dose mentioned in the DICOM header, and we multiply it by the coefficient factor, so we get the effective dose. And we compare it with the other references published internationally. We found some correlation between that, but the main thing in this topic is that we have to verify the values that given by the system by using phantom studies. The ICRP publication number 93 emphasized on re-evaluating digital imaging, and also is to show the doses on the console. This is very important to keep the record of patient doses. IAEA also mentioned that the frequency of examination need to be also looked through, because of the digital radiology, it's easy to perform the procedures. Here, I come to the experience of the DHA in evaluating patient doses. In general radiology, we carried out a study on in a pediatric hospital, and the method that we used was that using patient data collection and phantom studies. Phantom studies, we carried it out to make sure that the values we get from the DAB systems can be trusted, and we see the level of the variation. We used phantoms as breast pics, and we used it for different sizes of patients. For neonatal, we used 10 centimeter. For the other group of pediatric, up to 15 years, we used 15 centimeter. And we used this dosimeter, we used this geometry, like with phantom and without phantom, and we found this method actually very complicated, and it needs a lot of calculations. This is the data that we have. We obtained data on abdomen and chest X-ray. We can see that the doses increases with the size of the patient, or the age of the patient, while in the chest X-ray we see that some of the fluctuation, maybe it's well presented here. So if you see here that the doses in this age group less than the younger age. We have actually a few data on this, because the pediatric age group for us is 13 years, not as internationally 15 years. This is the abdomen data. We don't see the fluctuation in the abdomen data. If we look to the ICRP data, which is published, we can also see there's some fluctuation in the age, as we found it with our data. For the general radiology, the phantom studied, we compare the different machines that we have in different places, and we looked into here the variation between the recorded doses and the doses that we measured. We have obtained a variation between 30% and something like 2% between the measured and the calculated. I mean, calculated is the displayed one, which is measured by the system. Here, the data on adult, and we compared our data with some published data. With the values that we have found are much lower in some other published data, but still we are not saying that these are final data, because the sample that we use is small, so we are still in the progress of looking into the more data on that. On mammography, we also followed the patient collection data, and we followed the phantom data, and we carried out this work on conventional mammography and on digital systems. We used these equipment to measure the ESAC value, and in each of our work, we look into the image quality, and we have radiologists with us in the team. This is our data on conventional radiology, but here to show you the same data, which just now on the table, presented as a graph here, you see that there is a large variation, and this is actually not only Dubai Hospital, but we have other hospitals within the Emirates with us. This is the digital mammography. If we look to the value we obtained here is 2.5 milligray. If we look to the digital values, they are well below that the value which we obtained on conventional. This is just a diagram showing the same data that I have presented. Here, the variation that we got between the dose that shown by the system and the dose that we obtained by measuring it. For interventional radiology, also we have two methods. We followed the gaphachromic film, and we followed the data collection. This is our old data that we looked into the range of the exposure within the IR system. The majority of doses were below 0.5, and we don't have any above 4 gray. The form that we use to collect the data is this form, which is actually, this is part of IAA project. So we distributed this form to the hospitals and we collected the data. This is for the pediatric, organized according to the age group. This is just also a diagram showing the data. It's the average DAB value and the cumulative values. This is for adult, the fluoroscopy time. And here we compared our data on coronary angiogram with other places, and we found that we are within the range. This is the DHA. This is just to show slides presented by Vano in the conference. I want to show this, that to say that for angioplasty procedures, so our values were here, we consider them as high. For dental radiology, we use the dosimeter and in this procedures, and we also perform this on films and digital. We found a large variation, and the most important thing that we obtained from here is that these values for pediatric and adult, for pediatric the doses are lower compared to adult, and if we compare our data with other published data, we can see that our data is much lower, because mainly that we are dealing with digital, but while our conventional data are within published data. This is a comparison between film dosimetry and digital dosimetry. We can see that a big reduction is more than 70%. This is for pediatric, and this is for adult. So here to look into the percentage of reduction, as I mentioned, it's above 70% in almost all of the dental views. Also, we carried out our work on OBG. This is our data where we stated the DRL levels for the OBG. So we found from this experience that education is very important, especially that people, they are not familiar with the quantities used. So we organized educational program, and this is almost mandatory on all radiation workers within the DHA. We carry this every 3 months. So as a conclusion, we see that there is a large variation in those measurements. This is reflecting the variation of manufacture and the method used. Also, there is a need to establish a simple and well-established method for those measurements, so it's easy to compare the doses. DRLs for interventional radiology still need a lot of work to be done on it, and especially the pediatric group. The COMBIM CT, which has mentioned by Dr. Rihani, also because it's a new technique in our area, we have not touched it yet. Auditing is very important for us to implement. We have no well-established system for auditing, and automated DICOM dose extraction technique is needed, especially that we are dealing with a large, big data. And in our area, unfortunately, lack of qualified experts in the medical physicists limit our work in this. Okay, since the theme of this session is what do we need from ICRP in medicine, I highlighted here some points, and I'd like to have a discussion on this. Education is very important and it's needed. Re-evaluation of DRL, as it's mentioned in the ICRP 93. Simple methods, dose recording, and dose registry. It's more important to be uniform, accurate, and well calibrated. I acknowledge our team who worked with us on this. This is the list of people who worked us on this project. And at the end, I thank you very much for your attention.